We're going to switch presentations here for, I think we'll do Dr. Levy's after Dr. Calabresi. Dr. Calabresi spoke to us yesterday about how the immune system worked and what becomes dysfunctional about the immune system.
And hello again. Glad to see so many of you out here on Saturday morning. As Sandy said, we've already talked a little bit about the immune system and the bad cells and the good cells, and we talked about MS and TM a lot. And today I'm going to share with you some of the promising future strategies in trying to more specifically target the immune system. It's just next door with scientific sessions, and I'll tell you there are a lot of very exciting presentations going on with brand new data about how we might do this. I'm going to share with you just a few of the ones that look promising. The outline of the talk will be discussing these promising immunotherapies that are in development, and we're going to talk also a little bit how we're going to, the specific immune cells again that I told you about, which ones we think are bad, and I'm going to touch at the end a little bit on the issues of neuroprotection and neurorepair, although I think Sanjay Keswani will speak more about this in a whole formal lecture, but I think you can't think about treating diseases selectively just with blocking the immune system. That was just my task, but I did want to mention that these are very exciting areas, and there's a lot of promising work being done. Just heard a talk 10 minutes ago about a new drug that's in development that shows dramatic remyelinating capacities. So you've seen this busy cartoon before. I'm not going to go through it all other than to say that there are a lot of potential ways that we could block the immune system. And the more we understand about the immune system, the more we find that we could block different receptors here, there, or on the blood vessel walls, or on the cells that actually excite the T cells. And so there are a lot of different ways that we can approach this. If one thinks in a very broad way, you could ablate the immune system or the bone marrow, which makes the immune cells. You could just try to wipe out everything. And this is sort of the nuclear bomb approach, I guess, is that something's going wrong with the immune system. If you try to just wipe it out and start again, that might actually be one strategy. And so that there are people who are using this approach with large amounts of chemotherapy and then trying to rescue the immune system by transplanting the patient's own bone marrow cells that they were harvested prior to the chemotherapy back into them and let new cells come back, and hopefully they won't make the same mistake again. That approach has actually shown some promise. It does seem to totally stop new relapses in MRI activity. Groups around the world in Italy, Canada, and Chicago, and on the West Coast in Washington State have all come to the remarkably similar result that it does effectively block the immune system, but one does pay a price in terms of toxicity, so that during that period where you've wiped out the immune system, people are susceptible to infection. And just as I told you with Tysabri, a couple of patients got a very bad infection in their brain. Some of the patients in these trials have actually died from infection, and so that's not ideal, and that's not what we want. Could we be very smart and tricky and block the actual specific problem in each disease, so that the ideal case here would be that we know exactly what the protein is that the immune system's responding to. We develop a drug that looks like that protein but kind of tricks the immune system. And so what an altered peptide ligand is, a little bit of a protein that looks like the protein that the immune system is attacking, but it gets modified in a way that turns off the immune cells rather than turning them on. And so in the late 90s, we thought we'd found a specific protein that caused MS. There's a part of myelin-basic protein that appeared in animal models to be very activating and cause a disease that looks like MS. And when we took T cells from MS patients, this particular little protein of myelin was very activating in a large number of patients. And so this altered peptide ligand was developed, and it was given to patients, and the vast majority of them didn't seem to have much of a reaction one way or the other. A few appeared like they were getting better, but unfortunately, a few actually got worse. And so that the lesson there is that sometimes that all the preclinical data from the laboratory doesn't always work out in patient situations. And one of the theories for why the vast majority of patients had no response to this is that it may not be one target. So the bad news may be that the immune system starts targeting many different myelin proteins, and we can't just teach it to ignore one specific part of the myelin, that it's going to be a harder problem. So the vast majority of therapies that are showing less toxicity and some effect are someplace in between here. We're getting smarter about trying to figure out how cells get to certain parts of the body. So this is a little cartoon of T cells in the lymph node, and I told you on Thursday about how T cells can migrate to certain tissues. We know that there are some that allow them to respond to skin, some to the mucosa in the intestines, and some to the brain. There is some overlap between these, but perhaps we can target some of these. And in fact, Tysabri targets this area, but we're increasingly finding more that may be responsible for immune cell migration to the brain. So that certainly is cell migration to specific organs is a way of, and I'll show you some examples of that. So the major categories of therapies are, in addition to cell migration inhibitors, there are monoclonal antibodies. So we can engineer immune cells or antibodies just like that are in our body, but have them, we can make large numbers of ones that are specifically targeting certain cells or receptors on those cells. And there are several in development that appear promising. There are pills, and so a lot of my patients are asking me, well, okay, I'm doing fine on my shots, but when are you going to have a pill? And there are several that have actually shown promise in phase 2 testing that I'll tell you about. I told you already that this specific approach appears to have some problems with it. Let me just move on. So the monoclonal antibodies that have looked the most promising are listed here. IL-12 is a cytokine or an inflammatory protein that is elevated in MS brain tissues and appears to activate the bad guy Th1 cells. And so by blocking this upstream cytokine, one may have an effect, and in fact there are data that are looking promising. Teclistamab, or anti-IL-2 receptor monoclonal antibody, has shown promise in NIH trials in MS, and another group in Utah, John Rose, has published on this. So there are now 2 phase 2 trials showing that this drug seems to work. It's actually FDA approved for transplantation and is sometimes being used off-label in people who are refractory to other therapies. And so I think this one looks promising. There's a phase 3 trial ongoing now with teclistamab. Anti-CD20, I also spoke about. This is a way of targeting the B cells, which make antibody, and there are several ongoing trials in this. There's not a lot of data published yet, but again, this is one that we think is very promising. Anti-CD52, or Campath, is a way of knocking out many of the memory T cells, the ones that we think that are sort of more persistent and may be bad cells. And there is a large trial going on with this. And natalizumab, as you already know, this is Tysabri, is now FDA approved again and is an effective monoclonal antibody. So these are drugs that, one of the nice things about them is that they can be given relatively infrequently. They do still have to be injected, typically through an intravenous catheter, but most of these are once a month, or in the case of rituximab, every 6 months. So a lot more convenient than taking shots on a regular basis. So the IL-12, as I told you about, is a way of blocking the Th1 cells. I will point out that one potential downside of blocking the Th1 cells is that some of those are needed to fight off infection. So again, we're always going to have to balance the level of these drugs and maybe not give too much or give them too often. And as I mentioned, there's several ongoing trials, but no published results yet. The Xenopax, I mentioned the 2 phase 2A studies suggesting 70% reduction in active MRI lesions and decreased clinical activity. There's an extensive experience with this drug, which makes it appealing because it's been given to lots and lots of people in other situations. And there's some interesting data that's being presented by Dr. Bielakova, who is next door, showing exactly how this may work. It may not only block the IL-2 receptor, but it seems to result in activation of a regulatory kind of cell that may dampen the immune response by one cell sort of talking to another cell. And as I said, the phase 3 trial is ongoing. Rituximab depletes the B cells, given every 6 months. It's already FDA approved for B cell cancers or lymphomas. No data yet in the MS studies, but there are these 2 large ongoing studies, and it's been suggested that it could work for both relapsing remitting and for primary progressive MS, which would be nice because we don't have anything that works in that disease. And just to remind you why blocking the B cells may be good, the B cells are the ones that become plasma cells and they make antibody, and we know that these immunoglobulin or antibodies are in the spinal fluid of a lot of our patients. So by blocking the precursor cells to this release of antibodies, we might ultimately affect antibody concentrations. But as I also told you on Thursday, B cells do other things. They release some of these inflammatory proteins like interleukin-6, which Dr. Kerr's shown to be very elevated in transverse myelitis. So maybe by blocking B cells, we could ultimately reduce IL-6 levels. And that's one of the appeals of rituximab in TM or Devick's disease, which is the neuromyelitis optica, would be to block this sort of upstream mediator of IL-6. And then the B cells crosstalk with the T cells, and they present the proteins. They say, here's a protein to look at, and can be activating for T cells. So by blocking B cells here, it may be important. And I think I also mentioned on Thursday that B cells are a reservoir for some infections. So the monovirus, Epstein-Barr virus, tends to live in B cells. And so for those people who might have had a very bad case of mono, we think there's a possibility that they may have more B cells that are infected with that virus that persist and continue to prime the immune system. And so there's a lot of interest in that whether rituximab may lower the number of infected B cells, and that when the new B cells come out 6 months later, they hopefully would not get reinfected again. So all of these different mechanisms are in play, and we're very excited about this drug. Campath is a monoclonal antibody that's mostly been developed in England. In fact, it stands for Cambridge Pathology Laboratories in Cambridge, England. Depletes lymphocytes. It's dosed once a day for 5 days, and then you're done basically for a year. And in the initial trials, there was a dramatic reduction in the gadolinium-enhanced MRI activity with no new inflammation for that period of time, so that this 5-day dose lasted for a very long period of time. The bad news in their initial trial was that over 50% of people continued to get worse over 18 months. But I think we understand this aspect a little bit better, so that you can't just stop the immune system and expect that the progression will stop at the same time. The two are somewhat dissociated, so that we now understand that you have to block the immune system and the inflammation for at least a year, and then in the subsequent years after that, you would see a benefit in terms of progression. And that's because the immune system goes in and demyelinates the nerve fibers, and those nerve fibers that are demyelinated then will break up over the ensuing months of the first year. And so that only in the second year or third year after you've blocked inflammation would you see a slowing of the worsening of the nerve roots themselves. And so we still think that this is a good drug. It's just that it probably needs to be given sooner or earlier. One of the odd things that happened in this clinical trial was that about a third of patients on the treatment developed an autoimmune disease of their thyroid gland. And that has not been well understood, but one of the concerns is that if you block one part of the immune system, you could actually shift things in another direction. And fortunately, this hasn't been seen so far in the latest trial, and people aren't sure why that's happening, but we're studying that carefully. So the ongoing study that's happening right now is this Campath-1 versus Rebif. And as I mentioned, the thyroid disease doesn't seem to be present right now. What pills are coming out? As I mentioned, that there are several drugs that have shown promise. Liquinomod is a derivative of a drug that had been used in the 90s called linamide that showed a fair bit of promise in MS. However, there was toxicity specifically to the heart and so it was never developed further. But this drug seems to not have that toxicity, and in a phase 2 study showed 44% reduction in MRI activity. For some reason, there wasn't a significant reduction in relapses, but in some of these small trials, it's hard to show an effect on clinical measures when you're just using a small number of patients, so that I'm still encouraged by the MRI response, and I think a larger trial is planned. Teriflunomide was just published in Neurology. This is an oral therapy that's been around for a few years, and there was positive phase 2 data that's already been published, and this one's going to move forward for sure into phase 3. The fumarates are a class of anti-inflammatory drugs that have been studied in rheumatological diseases like rheumatoid arthritis, and appear to have been effective in a phase 2 study in Europe in patients with relapsing remitting MS. It met what's called the primary endpoint, or again, a reduction in gadolinium-enhancing lesions. And these data have not been published, but Biogen actually makes one of these drugs, and Biogen's experienced with MS, so I would presume that they would want to go ahead with further testing of this drug. Two that are particularly interesting because they're already available to people are the statins, or the cholesterol-lowering drugs, specifically Lipitor, and minocycline, which is an antibiotic. It's used for a lot of indications, and a lot of people take it for acne, though. And I'll point out that we have really relatively much less data about these drugs than we do about the other ones where there were placebo-controlled trials. And so I caution people who might think that they have availability to these from their doctors just to go out and try them randomly, because we don't know for sure if they work, and if you don't have high cholesterol, driving your cholesterol down to low levels could be dangerous if you're not monitored carefully, and taking antibiotics can be dangerous if you don't have an infection, because you can develop resistant bacteria. Nonetheless, they do appear exciting, and in a pilot study of another statin called simvastatin, there was a 44% reduction of active MRI lesions, and we're presently involved in a trial sponsored by the NIH in very early patients with what we call CIS, or a clinically isolated syndrome. So this would be optic neuritis or even a partial transverse myelitis, but with some brain lesions to suggest the beginnings of MS. And we're trying to figure out if starting a pill at an early stage like that might prevent the development of new lesions or a second clinical attack. Minocycline, as I told you, is an antibiotic, but it has anti-inflammatory properties, and it may even have some properties that protect nerve cells. And there are pilot data to suggest an effect in reducing MRI activity. Luann Metz in Calgary showed that in 10 patients that there was a significant reduction in MRI lesions, and she's now followed those folks out for 3 years. And there seems to be a decrease in brain atrophy, which gets progressively better over time, so that in the 3rd year, the reduction in brain atrophy was the greatest. So promising preliminary data, but again, I think we need to do a real placebo-controlled trial for 2 years and many more patients before we know for sure whether this is effective. And then finally, one of the most promising drugs that's probably the furthest ahead is FTY-720, and I'll have quite several slides dedicated to that. Before we get to that, I'll just point out that well, this is the category that I promised I'd talk about, cell migration inhibitors. The Tysabri story I already spoke about, so I'm not going to mention that too much further, but that blocks cells from getting from the blood, across the blood-brain barrier, into the brain. And there's some other promising approaches. Dr. Ransohoff is here. He's the world's expert on chemokines and chemokine receptors. These are chemoattractant surface receptors that send signals to other cells and say, come over here, this is where the inflammation is, and if we could, maybe we don't need to block the very first cells that get in there that are recognizing the myelin, but what we need to do is prevent the party from getting out of hand, if you will. So that's what this approach is. It basically shuts the door and says, okay, a few of you got in, but we're not going to let 100 people into a room that's only supposed to have 5 or 10 cells. So these look promising, the whole series of drugs. But FTY-720 is one where we already have clinical data. This is a drug that also blocks cells from migrating. Specifically, it seems to trap some cells in the lymph nodes so that they can't get out and get into the brain and spinal cord. and in this clinical trial of over 200 patients, there was a greater than 50% reduction in clinical relapse rate and an 80% reduction in MRI activity. And this is a pill form, unlike this. And so that was encouraging. It was pretty well tolerated. So here's the promised cartoon about how this works. So here's a lymph node, and normally in the lymph node, the T cell sees a protein and then says, okay, I'm going to go looking for that protein. It leaves into the blood and then finds that protein in the brain. The brain gets more damage, releases more of those proteins into your cervical lymph nodes, and the process sort of propagates itself. And the idea here is that the more we understand how cells sort of take off from the lymph nodes and go off and attack proteins in a bad way, the more we can block that process. And one particular receptor that's involved in doing this is called the S1P receptor, and the drug in this case kind of comes in. It actually mimics S1P and tricks the cell into thinking that it's seen the S1P, and the receptor internalizes and so is no longer able to function. And so it's a way of tricking the immune system, and it decreases the number of cells that are going out and doing their thing. Interestingly, and very importantly probably, is that this drug seems to selectively block the cells that are in the lymph node, so that memory cells that are already responding to infections that are out in the circulation are not affected by this drug, so that presumably in the clinical trials there has not been a dramatic increase of infections, and so that the cells that are already out busy fighting off infection would not be affected by this drug, which is encouraging. So here's a more detailed slide of what I just told you, that in terms of the benefits, statistically significant and clinically relevant effect of FTY-720 at two different pill doses, a 1.25 milligram dose and a 5 milligram dose, as compared to the placebo pill, both on MRI and relapse rate. The relapse rate was 50% reduction, MRI 80% reduction. No difference between these doses, which was a little bit of a surprise. In many of their early trials, one tries to find the most effective dose, and so we try higher doses. And the good news is that even a low dose seemed to work. It was generally well tolerated. Very few people dropped out of the study. It was a 6-month study, and then there was a 12-month extension. So we now have data from about 18 months of exposure with this drug. There were some minor side effects. It seems to decrease the heart rate after the very first dose, and then that problem seems to go away. There's a potential concern in a very small percentage of people about whether it might have some effects on the lungs. So again, we worry that these things are not absolutely specifically targeting everything that happens in MS, and there could be other side effects. So we're going to, in the phase 3 testing, there's going to be more extensive monitoring. And I think the FDA, after the Tysabri story, is very keen on sort of trying to prevent any future problems. So there'll be heart testing and lung testing and all sorts of other things to make sure that this isn't a problem. But again, so far after 18 months, there have been no serious problems here. It's just a very small change. There was a very slight change in blood pressure by about 6 points. And as many of you know, if you're anxious or stressed by a traffic jam, your blood pressure can go up by 20 points. So we think that this is relatively little change. And there was a very minor change in one of the liver function tests, which again was not a major problem, and it was only really seen in the higher dose, which appears to not be necessary. So hopefully by going to a lower dose, some of this will just disappear. I'm not going to go through all of these, but this is all the different targets that we're talking about next door. I told you Dr. Ransohoff is an expert in chemokine receptors. Dr. Viwei Yang from Canada and Kathy Conant here from Baltimore have done a lot of nice work with this enzyme, which helps the T cells burrow through the blood-brain barrier and get to the other side, and have suggested that maybe by blocking this we could have some effects. So there are a lot of exciting things happening in this arena. Continue to be things happening in the lab. So for those of you who I think there's a public perception that a lot of the NIH-sponsored research doesn't lead to anything, but what I would like to convey to you is that this is a process where there's a pipeline of things happening. And so We continue to try to find things in the laboratory that are targets. We test them. We pass them over to people who are doing the clinical trials. And then it goes from phase 1 trial testing, phase 2, phase 3. So many of the things that I just told you about that are already in phase 2 trials were developed 10, 20 years ago. We're trying to develop the ones now that will be available for the next 10, 20 years. And there's some very promising, more selective ways of blocking immune function that we're optimistic about, but they're not ready for prime time yet. A little bit more about minocycline, because I think people are always interested in this because it's already available and relatively safe. So I told you it's anti-inflammatory. It prevents cells from dying. That's called apoptosis. It interestingly reduces the level of activity of this enzyme that I just told you about that helps the cells cross the blood-brain barrier. It also inhibits cells that are inflammatory in the brain. The microglia are some of the immune cells in the brain, and so this is a drug that actually has been shown to have some effects on inhibiting microglia, and we don't have anything that does that. The MS drugs right now, the interferons and Copaxone, right now we think mostly act in the peripheral immune system, but this would be interesting. There even is some evidence that it may reduce the amount of damage to the nerves or the nerve wires that we call the axons, and minocycline reduces clinical worsening in a wide variety of both in culture models and animal models. Many people, some of them here, have published on this data. And then I told you about Luann Metz's clinical trial. So again, potentially promising. Just by way of closing, I'd like to point out that what I started with on Thursday was that MS and other neuroimmune diseases are partly about the immune system, and so you've heard a lot of focus on trying to block the different immune cells, some of them in the blood, some of them in the brain, like the microglia and the astrocytes, and different types of T cells. I think we need to be a little bit cautious because there was another lecture next door this morning by Dr. Robin Franklin, who studies how the brain remyelinates. And he's found that sometimes if you block the immune system, you can actually prevent the remyelination, and that some of those immune cells may be releasing signals that are good. And so we don't want to block them all. I think that's an important lesson, that maybe that nuclear bomb approach is not the best thing, or if we do it, we just need to do it for a very short period of time and then allow new immune cells to get in there, because it appears that some of the immune cells are actually regulating the response or enhancing the healing response. And I told you about T regulatory cells, the so-called, I call them the Red Cross cells that come in and after the war is over and bandage people up. And increasingly, we're finding that this is important, and maybe we can actually capitalize that. And if we can understand how to get those cells to grow up and go into the nervous system, that would be important. And then, just as an important advertisement for Dr. Keswani's talk, that there are lots of things that happen in the brain that are not inflammatory. So going back to the analogy of the tree that's lost its bark, if you come back to that tree a year later and there's no new bark there, that tree is going to be exposed to the elements, and in later stages of the disease we need to think of more clever ways of trying to prevent the trunk itself from degenerating. And is it possible to get stem cells or neural precursor cells to come in and remyelinate in chronically demyelinated areas? Can we actually just protect the nerves themselves? Can we protect the trunk of the tree without myelin? And there's some suggestion that we can through various different approaches, providing growth factors to those nerve wires themselves, or blocking some of the downstream mechanisms through calcium. We know calcium kills cells, so can we just block calcium entry into the nerve axons and prevent injury? And I think the answer so far in culture dishes is yes, and in some of the animal models, the answer is yes. And there are even some available drugs, like some of the seizure drugs, that we are finding block calcium entry into nerve cells and are going to be tested very shortly as neuroprotective drugs. So to conclude, MS and many of these other neuroimmunologic diseases are inflammatory, but also have a nerve or axon damaging degenerative component to them. There are partially effective immune modulating drugs for relapsing remitting MS, but there's a need for more effective and better tolerated ones. And I hope that you come away today sharing my hope and optimism that there are many promising monoclonal antibodies and oral agents that are well into development that where the phase 3 trials hopefully will yield the fruit and make them available to everyone in the near future. So thank you for your attention.